Yes, go ahead, Dr. Yeah.
Yes, I would like to share with you a couple of issues. I am a medical oncologist for 37 years, and I agree totally with quality of care, but a couple of comments. One, it is needed a clear strategy. This is the same situation with pap smear. Pap smear is very good, but it is impossible to apply pap smear in order to avoid cervical cancer because it is not available. So, with regard to with the presentation, one issue is that it is possible to select curable cancers, and you can select populations in which this is needed. You can train people for only palliative care with single drugs, are not all the sophisticated myriad of new things for 1 week survival time. It is necessary to develop new tools. I agree with both positions, because with the current training of medical oncologists, they are not trained for this situation in limited resources. But there is a need for chemotherapy from the healthcare point of view to provide the correct and proper use of chemotherapy regarding the effectiveness to certain populations. And that tool doesn't exist yet. As an example, we published 15 or 20 years ago in the Journal of Cancer Education and Evaluation about medical doctors, young medical doctors in the University of Buenos Aires and their knowledge about cancer, general doctors. Surprisingly, the level of knowledge was similar to the general public. So we developed a 20-hour course, 20 hours. At the end, with the same questions, they were with a very important improvement of knowledge. So, with a new tool, in order to design proper trained physicians for certain populations according to the real needs, that could be a strategy that, from the healthcare point of view, should be discussed.
Yes, go ahead.
Just a little addition. I think we are not using some of the tools at hand. When you come to Ghana, for example, we have a lot of nurses, and oncology nursing is something that we should try to incorporate in our training curriculum, especially in the nursing training that we have all over. If we train more oncology nurses, I think the work will be much easier, because they will take off most of the job from the medical oncologists that we don't have. Thank you.
Before I give the microphone to Ben, let me just say one thing, a comment. I think we'll have to come up with some agreement, some sort of agreement that in medical and chemotherapy, first of all, let's not down medical oncology is not just the doctor who administers only chemotherapy. Our role is much bigger than that. But we all agree that treatment could be given by maybe medical oncologists or supervised by medical oncologists. There has to be a communication. We do not recommend, I don't think anybody recommends that treatment can be given by other people not trained. We want people to be trained and supervised by medical oncologists. Ben?
So the point that Dr. Khaled made about medical oncology, you know, we just finished the ASCO meeting. I think if you surveyed the oncologists at the ASCO meeting, the vast majority would have agreed with Dr. Khaled that, of course, you need to have medical oncologists, and yet we have this reality problem. In the context of what we're going to be publishing, we need to be very careful about how we communicate on this. The major criticism that BHGI receives, it comes mostly from mostly from the American community, is that we're certifying substandard care. that we're really saying it's okay not to do everything because, in fact, that was one of the points in the first Global Summit, Alex, that you had raised. So what we need to do is make sure that we're communicating clearly that we're not lowering the standard of care. We're figuring alternate methods that will help us get to this place so that the patient actually receives their care. One final comment, which is neither Naji nor Alex talked about measuring how does the patient actually get everything that was prescribed. We only talked about the planning, but we didn't actually say, and of the patients, how many made it all the way through that chemotherapy protocol? And we really have to think about that as well, because that will determine disease outcome. We're just out of time. Can we do the final? I'd like to repeat the question that we just did to see if anyone has changed their opinions to those two questions. Here's one more. Okay. Dr. Massetti has a comment about the question we're about to look at.
Your final comment. I think that's very important. Just very quick comment on that. Because I think that the criticism that BHGI has received comes up all the time. And I don't think we are reinforcing in any way suboptimal care, but you have to acknowledge that the care that is provided right now in many low-resource countries is suboptimal care. So while we are not suggesting or promoting suboptimal care, we are trying to figure out ways in which suboptimal care can scale up to suboptimal care and sometimes optimal care. So I agree with your comment that this should be our end goal, to have more medical oncologists, but that will require time. And in the meanwhile, I think that our duty is to suggest some strategies that can help to bridge that gap.
Thank you. Here comes our two questions. So first, do you believe that cobalt radiotherapy is it an outmoded therapy? Is it an appropriate tool for low resource settings, or should we only use it when linear accelerators are not available? Interesting. Interesting. That was a change. Yes. And can we go on to the second question, Carol? So cytotoxic chemotherapy should not be provided in the absence of medical oncologists, can be provided in limited resource settings by general clinicians, is unnecessary in most low resource scenarios due to advanced stage disease. Go ahead. Very interesting. So let's resume. No. We're going to resume at 10:40. You'll have another opportunity later. And so 10:40, we're going to come back and resume for our second morning session.